So to get us started this evening, I would like to introduce our guest, Dr. Jen Gunter. She's an obstetrician gynecologist, a pain medicine physician, and an internationally renowned best-selling author. She's written several books, including The Vagina Bible and The Menopause Manifesto. Her writing has also appeared in the New York Times, the Globe and Mail, Glamour, and Chatelaine. Dr. Gunter is the star of Jensplaining on CBC Gem, and she hosts a podcast, Body Stuff with Jen Gunter from the TED Audio Collective. This evening, Dr. Gunter will be speaking a little bit about her book and her advocacy on women's health, and we're then going to open it up for questions. So I'd encourage you to please put your questions in the Q&A, and we'll get to as many of them as we can. Over to you, Dr. Gunter.
Oh, well, thank you. Thank you so much for having me, and hello to everybody in Ottawa. It's a city close to my heart because my son is actually at the University of Ottawa. So he's loving it there, and I go and visit him. Well, not frequently, but enough to keep track of my son in second year at university. So anyway, so I'm finishing up my book tour for Blood, which is really everything that I want everybody to know about the menstrual cycle. And, one question I often get asked is, who's this for? And obviously, the easy answer is, well, it's for people who menstruate, because you need to know about your body, how it works, so you can advocate for yourself, because it's very difficult for people to often get the healthcare they need, either due to the overtaxed healthcare system, or due to systemic inequalities in research, or due to the fact that it's difficult sometimes to access healthcare. And so obviously it's for all those reasons. However, I always like to say that every single person on this planet is here because somebody had a menstrual cycle. So every person has benefited from a menstrual cycle. Humans have menstruation. Most mammals have estrus. And a menstrual cycle is something that makes us quite unique. And it is the reason that humans have been allowed to have such big brains and have the kind of, development that we've had is in large part due to the menstrual cycle. So if you're watching this on a computer, that computer exists because somebody had a menstrual cycle. So it's not just something that matters to the people who menstruate, but it matters to everybody. Also, if you have a lover who has a menstrual cycle, a partner, a wife, if you have a child with a menstrual cycle, if you have a friend, knowing about it helps you be a better advocate. And especially if you're a parent, there are so many myths and so many lies about the menstrual cycle, and so many people suffer without getting the right care. Don't you want to know about that so you can help your child have a better life, so you can start them out right? And so people often ask if I'm going to write, a children's book or a book for teens. And I'm not an author for 10-year-olds. So that's really a very specific skill set. However, I am an author for people who are parental age. And if you have an 8 or 9-year-old who's going to menstruate soon, for you to learn about it would actually be really beneficial. So when thinking about this book, the idea came to me because I just finished writing a book about menopause, and so many questions about menopause really could be answered by knowing more about the menstrual cycle. So when people ask, for example, about hormone testing or ask about hormone levels, if you understood the menstrual cycle, you'd have a better understanding of that. So I realized that we needed to have more information there. And this was in the very early days of COVID, when the vaccine was first rolling out, the vaccines. And there were all these, lies on social media about the vaccine affecting fertility and people shedding spike proteins, things that were not biologically possible. And if you had an understanding of the menstrual cycle, you'd know that that was, clearly a scam. And also around the same time, there was this kind of rise of disinformation about the birth control pill. And there's really, I would say, almost a sort of fetishization, I don't know how to pronounce that word, on social media, with sort of these whole like trad wives. And this is really kind of in part of that. And so, this idea that that all of this disinformation is thriving in the same environment that allows people to not get the care that they need. So a really good example that I give why something like this book is important and why knowledge is power is, we know that 20% of women who are 22 years and younger are iron deficient, related to the blood loss from their menstrual cycle. And it shouldn't be that way. And this is a really great example of, how knowing what is heavy for a period would allow you to say, hey, maybe I need to go get checked out because I'm soaking through a pad an hour or a tampon an hour, or I'm, soaking onto my clothes, or I have clots that are bigger than a size of a quarter. Because people might tell you that you're going to get a period. Maybe you've read Judy Blume, or you hear about periods on social media, right? Or it's talked about in magazines, but nobody ever talks about the specifics, like how much blood there is, right? And those are really important things, because if you don't know how much blood there should be, then how would you know if you're having a heavy period? And, in my own practice, I used to ask people if they had heavy periods, and almost everybody said no. And I'm like, well, that's not really possible, because I'm looking at your blood count. I know you've got heavy periods. And so I really started framing it in a way of, how, do you have clots that are bigger than the size of a quarter? Are you soaking onto your clothes? Are you bleeding for more than 7 days? And I would uniformly get the answer of yes, 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 which would match their low hemoglobin and match their low iron. And so, but if nobody tells you what's heavy, how would you know? And iron deficiency is really a good example of all of the systemic inequalities, and why having knowledge is really important. So even though iron deficiency is really common for women, it's brushed off as just being something you don't need to worry about. And so many women take iron for years and years and years, and it never gets their blood count up, or they stop taking it because oral iron is awful. It makes you constipated or upsets your stomach. Nobody's happy when they're constipated, right? So there's that. And now we have amazing intravenous iron we can give to people, but there's a lot of gatekeeping with that, because the healthcare system doesn't want to pay for expensive iron. So they make it very difficult for people to access. And in addition, and this is something that, I hope people find very enraging, is the guidelines for what's a normal iron level are different for men versus women. And this has historically been allowed because, of course, testosterone makes you very strong and you need to use more oxygen. And I'm always like, well, excuse me, but pregnancy is the most metabolically taxing thing a person can do. So it doesn't make sense that the person who can get pregnant should have less iron in their body.
Mm.
Thinking about it that way. And so when the guidelines were written, nobody thought that maybe iron levels were lower for women because they're losing it. No, the answer was clearly testosterone makes you stronger, and you need to have more oxygen, and you need to be able to carry more oxygen to have more hemoglobin with your man, which is really fascinating because, they accepted the fact that iron levels for children are the same until puberty. Then, oh, what happens? So it drops for women, stays like this. And then, oh, with menopause, it goes back up. Obviously, that's testosterone. Obviously, it's laughable when you think about it, but these are the standards that were allowed. So, if you understand about how your body works, you understand what's heavy and what's not heavy for bleeding. If you understand about the problem of iron deficiency, that it can cause brain fog, hair loss, restless leg syndrome, makes you crave chewing ice, all kinds of weird things that iron deficiency causes. It's a very important chemical in our body, or mineral in our body. If you understand the consequences of it and you understand the treatments, you can advocate for yourself. So I would say that, iron deficiency in a nutshell is kind of a reason behind the book. But, whether it's understanding that, on social media, that you can't balance your hormones with diet, it's not possible. That's not how it works. Your hormones aren't made by the food that you eat in that way. So if you can't balance hormones, or that, there's no blood work to tell if your hormones are balanced, learning all of that also allows you to advocate for yourself. Because, when I first started practicing medicine, and certainly when I was a teen with my period, I didn't have to deal with social media. We had Reader's Digest that told you, put an onion in your sock, or, there's a little bit of medical misinformation there, but nobody was reading Reader's Digest when you were 16, so that wasn't a problem. And Tiger Beat didn't really write about periods, so we didn't really have access to that disinformation. But so now what you have on social media is you have these uncurated, non-experts putting out all kinds of disinformation that comes at you like a fire hose. And because they're influencers, we trust influencers. That's how they get their name, influencer, right? So they influence you, and they're talking about hormone diets, or they're talking about how hormonal contraception is evil, all these things that aren't fact-based. And the thing that is really concerning, that, really has repercussions far beyond just my book and the menstrual cycle is the impact of propaganda on social media. And that's something I talk a lot about in the book because it's very important from a health standpoint, but it's also very important, politically and just to how you live your life in general. So I always tell people it takes 5 exposures to what you might think is crazy disinformation for you to start to consider that it might actually be true. And how crazy? The tallest person is 35 feet. The earth is a perfect square. More people live in North Dakota than in New York State, right? So those are things that Abraham Lincoln was born in China. So statements like that, I would like to think that everybody watching would be like, what? Like, just completely rolling their eyes. Those are statements that if you're here 5 times, you might actually start to move the needle a little bit. And so it's really important for us to understand that when people are on social media looking for health information, or even not looking for it, they're consuming social media, that they're going to be met with these sort of these propaganda lies over and over and over again. And if you watch one video to the end, then that tells the algorithm you want more of that. If you watch it, 80%, it tells the algorithm. The algorithm is so smart and it's very fear-based. And these influencers understand that. They know that they need to sell you fear to get you to watch. And if the more you watch, the more that you believe the propaganda. So, my book also contains a lot of information about how to determine who you should be listening to online and who you shouldn't be, and how to tell the difference. I mean, if someone's selling you a supplement, now we have this whole group of people that call themselves period coaches, right? I know whenever I say that, people are like, what are you talking about? I'm like, I know, but you can put the word coach after anything. And, all of a sudden you can charge $100 for your hour time, $100 an hour, maybe 200, who knows? So they're telling people that they can fix your period with diet. And these people are also telling you need to come off birth control. But of course, they can't fix your period unless you come off birth control, right? So it's a big business model for them. And there's a lot of intersection between this disinformation on social media and extreme sort of right-wing beliefs. So beliefs that women shouldn't have jobs, belief that women should be at the home, and beliefs that women should have, as many, children as God intended. And certainly if that's your belief, you're allowed to have it. But it's one thing to have that belief. It's another thing to have it as a soft sell to kind of get you in. And so, many of these accounts are really thinly veiled like that. And I always tell people, the birth control pill is responsible for 40% of women's economic gains. So the ability to choose when you get pregnant, for those who partner with people who can get them pregnant, is an incredible economic tool. The ability to have sex, for pleasure is something that is really a relatively new concept. So people, sex with pleasure and not bear the ramifications of multiple children is really a relatively new concept. And certainly in the United States, something that we should not be taking for granted. We have multiple states where abortion is illegal. We have these states, you've probably all heard about, in Alabama, and they went after IVF, but they're certainly going to be coming for contraception too. And what the ramifications of those are. So I always tell people in Canada, you're not as far removed from that as you think. And if a politician is mentioning it, they've been thinking about it, they've been dreaming about it, they've been salivating about it for 10 years. And these extreme beliefs, unfortunately, in the United States anyway, get a lot of fundraising and they get a lot of attention with the press, right? Because they're extreme. If you're like, hey, exercise for everybody, that's my political agenda. Like, who wants to cover that story? First of all, no one wants to exercise. I mean, maybe there's some people who do. I'm honest, I do my exercise, my required exercise every week. I think it would be really hypocritical for me to be preaching about it in the office and not do it. But I hate it. I've never had a runner's high. When I'm lifting weights, I hate it. It hurts. I'm having to push hard, right? I would take a pill if I could replace exercise. I absolutely would. But if you're running on that, and that's again a great example of how that doesn't sell on social media, right? The idea that you have a special diet or a special pill does. So when politicians have these real extreme beliefs, what happens is that consumes all the media. Now, again, think about what I just said about propaganda. You hear these things over and over and over again. It's not just on social media. The sort of the regular media is also carrying that. So it's really important to have that consideration. Another thing, another real big pitfall on social media is something called data voids. So a influencer will make something up, whatever. You need to have carrots every day to balance your estrogen. And I'm not kidding. That's something from a couple of years ago. These things are fads, right? So all these people were making carrot salads and eating carrot salads every single day because they truly thought it was better for their estrogen levels, right? I mean, carrots are good for you, but you don't have to eat them every day. And so if you went to look that up online, you wouldn't find any credible information because it's not a thing, right? Doctors, like, the idea that carrots can balance hormones is medically illiterate. So there isn't going to be information from the World Health Organization. There isn't going to be information from Health Canada. People who write legitimate information aren't going to cover it. So then when you go in and Google carrot salad menstruation, what happens is all these low quality sites, blogs from influencers, the sort of natural news type sites, places that are very anti-vaccine and things like that, all of those, because they all talk about the same scams, those come up and it makes it look very legitimate. You see all these hits and you think that it's true. So that's just another reason why doing your own research can be a really challenging thing. Someone has to teach you how to do that research online. Just like if I was trying to look up a law or look up something related to, that's not in my field, it will be very easy for me to get tripped and go down a rabbit hole and find a place that isn't giving me accurate information. And so I talk a lot about that in the book too, about how to actually do research online so you can protect yourself. A lot of people want to know, like, what's a surprising thing that I learned while researching the book. And I mean, none of the medicine was really surprising, although there's a couple of really cool facts that things you forget about, you like learn, and then you're like, oh, I forgot about that. And one of the coolest things I think is the innermost muscle layer in the uterus. It's got 3 muscle layers. The innermost layer kind of has waves of contractions. And it makes me think about, outside of car dealerships, those things that wave back and forth, it makes me think about that. Except in one time of the cycle, they all undulate in one direction to move sperm upwards. And around menstruation, it moves in the other direction to get menstrual blood out. Isn't that really cool? Biology is like really cool. You think how, like, evolution, man. I always want to think, can I swear on this? I hope I can swear. I'm going to say evolution, like, what the fuck? Like, but then you think, ducks have corkscrew penises, and there are, all kinds of crazy things in evolution. So of course, but I think that's one of the coolest facts that, that I remembered. But the things that I learned in the book that I didn't really know were the history lessons. So, because we don't do a really great job about teaching the history of medicine. And one of the things that I found actually kind of sad, but also fascinating, is I got very obsessed with the idea of what did our ancestral mothers do for menstruation? Like, what did they use? Because you see all these, like, people with their accounts on Instagram talking about what the ancients did and what's natural. I'm like, did they really wrap moss around a stick? Like, did they really do that? Because I don't really believe that. And so I went down this incredibly long rabbit hole where I was in for probably several weeks trying to find information, reading dissertations and textbooks. I have a very large collection of old medical textbooks from the early 1800s. Nothing mentioned about how to actually, they talk about diseases they associated with the uterus, but no actual menstrual management at all. There is a textbook written by a midwife from the 1600s. Nothing about menstrual management at all, although she also doesn't talk about how to, clean yourself after going to the bathroom too. So, maybe it was just common knowledge. But one thing I found was really fascinating was this woman was working on her PhD at the University of Iowa, and I found her dissertation. And basically what she did was she looked at diaries of women who had, crossed the American West during the gold rush, right? So in the early 1800s, and these diaries were really very, very detailed about, like, how many shirts you should take and how many pairs of shoes you should have, like what it takes to cross, into California. But they didn't write anything about menstrual products. at all. And so she took all these diaries and then charted out when women might have written when they were sick or when they were poorly, to see if that might like correlate. Like, did that show up every 25 days, every 32 days? Like, was there a correlation with that? Because maybe they're using euphemisms like being sick or poorly for their menstrual cycle. Nope, nothing at all. And so it's this idea, this pervasive shame about menstruation being so, your body is toxic, your body is polluted, which of course, really it's toxic and polluted, but an embryo is going to implant in there. Like that makes no sense, but the patriarchy doesn't make sense. So you have these women who even in their own diaries couldn't write about what they used. And so, women almost certainly just used what they had at hand, extra rags, extra pieces of cloth, put between their legs. And those who didn't have that didn't wear anything. Um, you know, People probably bled onto their petticoats in older times. And some women would have taken to their beds, right? And it would have been easier to manage that way. But yeah, so even in women's own private lives, discussion about menstruation seems to be taboo. One of the only public records talking about menstruation, and I can't remember the actual date, if it was the late 1700s or early 1800s, was a woman actually testifying to save her life in the Old Bailey in London, and she was accused of murdering the woman she worked for and two other two other maids, and one of the people had their throat slashed, so there was blood everywhere, and she had blood on her petticoats. And she was trying, and so, women did not speak publicly about their menstruation. And she spoke at her trial saying that the blood was, on her petticoats because of her period. And now the jury didn't, or I don't know if they had a jury in those days, but the judge didn't believe her. And she was, in fact, sentenced to death and hanged. But it's fascinating that, really one of the only public records that we have in our society is a woman was, pleading for her life. There was a lot of other like damning evidence. So I'm not saying that this was like, they found all the stuff that was stolen from the place at her house. So, there's some other evidence. They never found anybody else. So it's, I'm not saying that she didn't do it. I'm not the person to say that at all. The evidence was pretty incriminating, but I think that was also like pretty canny on her part, was to use something like menstruation, something that wouldn't have been talked about, something that like maybe the judge would have been too embarrassed to even process, right? It's a pretty smart tactic when you think about it, given the time and given the day. And the gamble didn't work for her, but I found that really fascinating. And I thought it was really cool that all the records were available online through the Old Bailey, so you could actually read her testimonies. So I found that really fascinating. Another fascinating and aggravating piece of history is about the IUD. So, the IUD has gone through kind of several generations, and the current generation is the one that, we all know. If you go to your doctor, that's what you're going to get, is the current generation. But the previous generation of IUDs, which is the same generation as the Dalkon Shield, which many people might have heard about, because it was associated with a lot of problems. That whole generation of IUDs, there were a lot of issues. It wasn't just the Dalkon Shield. So, the Dalkon Shield had a higher rate of infection, a higher rate of pregnancy associated with it, and severe infections in pregnancy, and resulted in deaths. And when the publication came out for that IUD, saying, "Oh, hey, we have this great new method, great new IUD," what wasn't disclosed was the participants were also told to use spermicide, which might affect the pregnancy rate, right? And it's super important, because if your IUD has a high pregnancy rate, then there's a high complication rate going to go with that. But people only know about the Dalkon Shield, but there were other IUDs that were problematic. And this is why IUDs are so regulated in the US and not in other places. So there was another IUD called the Magdalene Spring, which I'm going to describe, and it's really awful, but it's like a whole bunch of needles together, like an accordion with a thread through. And so you put it in, and then the needles would kind of open. And as you can guess, it caused a lot of uterine perforation. So the FDA wanted it removed from the market. But this was in the time before IUDs were under control for the FDA, so they couldn't force a recall. There was nothing they could do about it. But they were like, okay, well, we have to do something about it. So they were able to get lots of doctors to give up their stocks that they had in the office. But this one doctor wouldn't. He had quite a large stock. And so they had to send the US Marshals to his office to actually confiscate the IUDs. And it even gets worse because he was on the OBGYN committee for the FDA. So makes you think, right? And then there was the Lippy's loop, which was also an IUD that we all thought was great and fantastic, and it might have been, but again, studies were looser, shall we say, back then. And everybody thought the Lippy's loop was great, it was fantastic. And then there actually happened to be this woman who was in one of the trials for the Lippy's loop, and it's kind of just shaped like a weird, like a snake, basically. And she went back to Dr. Lippes himself and said she was having problems with it. And he said, oh, it can't be. It can't possibly be the IUD. You obviously, you silly little woman. What do you know? And so finally, after being dismissed by him, she went to another doctor who said, oh, yeah, sure, could be the IUD, and pulled it out, and she was fine. And the only reason why the FDA learned about it was she was the secretary at the FDA. So obviously, there was all kinds of IUD-related shenanigans that weren't getting through. And that is why, dear friends, IUDs are regulated like medicine in the US. So in the United States, uh, devices have much lower degree of regulation, which is bizarre because you can easily kill someone with a poorly designed surgical implant, right? But they have a lower bar. Medication has a much higher bar for studying. And people often say, well, the reason why we don't have very many IUDs in the US is these stupid rules from the FDA, and we require all these studies, and other countries don't require them. And what I say to that is, well, other studies have lower populations. So I don't know, maybe they have the problems, but they don't appear in the frequency. So they're not picked up. But it's also possible that in other countries, these devices make much less money for the manufacturers, right? So a Mirena IUD in the US is, I think, $1,000. It's $1,200 US to buy it, and they're $80 Canadian. And I know this because I was just on Cityline a couple of weeks ago, and they wanted me to show people how IUDs work. So they bought one and they wanted me to open it. And I was like, oh, are you sure you want me to open it? And they're like, what are you even talking about? I'm like, they're super expensive. And they're like, what do you think is expensive? Well, they're $1,200. And they're like, this was $80 at Shoppers. So it's like, 55 in the US. So to give you an idea of the price difference. So if you have a product and you're going to bring it to market, it's a lot longer for you to make a profit off of a $55 US device than it is off of a $1,200 US device, right? So being able to charge this massive amount, in my opinion, encourages people that haven't really done proper studies to enter into the market, because you can come into the market with a shitty device. You can get it implanted by a bunch of people, and then you can declare bankruptcy and you've made your money. But when there isn't that much money to be made, it's not going to encourage those people. So I actually think the lower prices in the other countries actually ends up protecting people from predatory. That's my opinion. I mean, obviously, I don't have any data to back that up. But in the United States, all we can say is unfettered capitalism and IUDs hasn't historically been a good combination. And it isn't just the Dalcon Shield; it's the Dalcon Shield, the Michelin Spring, the Lippy's loops. So the other thing with the Lippy's loop is, oh no, the Tatum T. See, there's more. There's so many problems with the IUD. They're a great device, but historically. So the Tatum T device, also another IUD, the guy who found out that the Dalcon Shield issue was related to the string, in his publication and in his presentation to the FDA, he didn't disclose that he was involved with working on the Tatum T. So again, maybe I doubt that affected any of his research, but not good optics. So that's kind of the middle era of IUDs in a nutshell. And for a period of time in the US, you couldn't get an IUD. So, and when I moved to the States, people were shocked that I put in so many IUDs in my training in Canada. They were like, what are you talking about? And I'm like, because it's an IUD. So because they also have the litigation in the state. So I would say that's the thing that surprised me, all that history. And there's a lot more of that kind of history in the book. And it's fascinating to be able to kind of match the history up with the medicine, because then you're like, oh, that's why that happened. Okay. And to kind of put all those things together, I go into the history of the birth control pill, and which is also, really fascinating as well. So a lot of good information. So I've been chatting for about 25 minutes or so, maybe 20 minutes. And so I know that we wanted to open up to questions as well. And so I hope there's people who have questions. I can keep chatting too, if there aren't any there, but talk about my favorite myths and things that you shouldn't. So I talk about myths next if there aren't any questions.
Super. Thank you very much. I'm sure we're going to have loads of questions. I've got a few to get the ball rolling. So the first one that I'm really keen to hear your opinion about is around the publications in the Lancet this week. So the Lancet published a series of 4 papers ahead of International Women's Day on menopause. And there was an opinion piece or an editorial that sort of introduced the series and expressed some concerns about commercial companies and individuals with vested interests over medicalizing menopause and concerns about some of the marketing that's happening. So I know,
Yeah.
having read your work, the role of the pharmaceutical industry and sort of the role of marketing and commerce, and as you just discussed, is something that sort of runs through your work. And I'm wondering sort of what your reaction is to that.
Yeah, so I haven't read all 4 of the articles that have been in that yet, but I've read the opinion piece. And it's really funny. There's been a lot of people very upset online about it. And I just want to say, like, did you read the same piece I did? So, maybe some of the language isn't what I would have chosen if I wrote it, but you have to remember, uh, things have to go through editors and all, so obviously as someone who does a lot of writing, you sort of, look at things that, sometimes you end up with a watered down version. And so I would say that, there's definitely parts of it I agree with. Menopause has been over medicalized in a way that that is concerning. People on social media, there are people who are led to believe that they are basically going to die because they're in menopause. And if they don't get on estrogen, their life is over. They're told that it's going to prevent cardiovascular disease, that it's going to prevent dementia. And not one guideline from any country recommends menopausal hormone therapy for those reasons. So it would be telling women that you're going to die because you don't get on hormones, that your brain is going to fall apart, that you're going to die of a heart attack, would be the same as saying to every pregnant person, you must have a C-section or you're going to die in labor. And if I said that, people would tell me I was over medicalizing pregnancy, right? Pregnancy is a normal process. However, it is also true that C-sections are very valuable tools. And hormone therapy, menopausal hormone therapy, is also a very valuable tool. It's fantastic for hot flashes and night sweats. It can sometimes help for mood disturbances, and it can help prevent osteoporosis. However, not everybody needs it for osteoporosis prevention. In addition, the number one thing to prevent your bones is building good bone mass in your 20s. The number one thing to protect your heart is a good diet and exercise. And so the other thing, when we keep telling people it's estrogen, 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 we're missing this whole holistic aspect of menopause. And so, if people are taking away that we shouldn't be prescribing estrogen from that piece, that wasn't my takeaway at all. My takeaway was, if you're on social media telling people disinformation about hormones, then you're over medicalizing, menopause. And it's interesting to me, all the people who got upset about it, that doctors are people who I would say are over medicalizing menopause. The idea that, for example, in menopause, we know that the 3 most important things for heart health, the 3 most important things: getting your regular exercise, eating a healthy diet, and not smoking. Estrogen is not in those things, right? And also, people conflate research. They say, oh, well, estrogen is important for brain modeling. Sure it is. But your estrogen produced by your body doing brain modeling is not the same as taking an estrogen pill, right? You have to study that intervention. And there's been a lot of work looking at, hormones and menopause. And if hormone therapy prevented cardiovascular disease, it would be in all the guidelines. If it prevented dementia, it would be in all the guidelines. And the truth of the matter is that we don't have good enough data to say that it does. I've seen doctors tell women that they need to be on estrogen and that statins don't work for them, which is actually completely untrue. Statins are the thing that prevents heart disease. That is the sort of the intervention that is life-saving. So I would say that I'm not sure I would have said over medicalization. I don't think that would have been the term that I would have picked. And so I think that's trumped up a lot of people. But I would encourage people to think about it kind of like C-sections and pregnancy. Pregnancy is normal, right? It's a life process. We don't need to medicalize pregnancy, but we should offer interventions to people who need it. Right. And that's the same with menopause. But telling people that they're going to die because they're in menopause and not taking estrogen, I mean, that's just wrong. So, and if you want to call that over medicalization, you sure can.
Yeah, that's great. Thank you. Next question we've got from one of our audience members. How do we normalize or destigmatize the conversation about menstruation among family docs to build menstrual literacy so patients know sort of what's normal, what's not in terms of, as you say, like iron deficiency, heavy bleeding, endometriosis, those types of things?
Yeah, I mean, I think the first is people need to understand with their own bodies what is considered normal and what's considered abnormal so they can present it to their doctor, right? So I always think about my own case. When I first started my period, I had catastrophically heavy periods and I was anemic for years. I didn't know that was abnormal. I didn't know it was abnormal to bleed onto your bed every night, 3 nights out of every cycle, right? I didn't know that was abnormal. I just thought that's why they call it the curse. This really sucks, right? So when you learn what's normal, then you can actually advocate. I think that, we ask our family doctors to do a lot, and many of them are asked to do incredible tasks in like 8 or 12 minutes because they've got 50 patients they have to see or 40 patients because there's so many people for them to see because they don't want to say no. And I would say that most of them go into it fairly well trained. I would say, I think what the problem is they're not given the time because there aren't enough of them. They can't actually sit and listen to the story. So I think that we need to start thinking about how to advocate at a government level. I also think it's really important that something like menstruation is taught more in school because unfortunately it's often glossed over as being kind of a woman thing or being something you need to know about. I mean, there's lots of things that are glossed over in medical school that are super practical that you're like, whoa, I didn't learn that till I got into residency. And so I think we need to do a better job of realizing what are sort of the core, what's the core curriculum? What do people need to know before they go out and see a patient? But you know what? I'd argue that an orthopedic surgeon needs to know as well, because everybody who does blood work on a patient is going to come across somebody who's anemic. And you should know that. You shouldn't just be like, oh, you're anemic. You should be like, hey, how heavy are your periods? And like, let's get you sent to the right person. So, so I think we can also make a case for having a better curriculum.
Yeah, that's great. Thanks. Another question in the chat is around some of the psychological issues that sometimes arise from menstruation. That individuals might feel that they haven't been heard by their physicians when they've had iron deficiency or other symptoms. Can you talk a little bit about some of those challenges that patients can face as a result of that?
Yeah, that's always a hard one because it's always hard to know what the actual issue is. Is the issue that they presented all these symptoms and they were told that was normal. They were presented symptoms and got a workup and couldn't get access to the care they needed. They couldn't get referred on to have the right kind of treatment, or they were diagnosed with iron deficiency and they were dismissed. So it's always hard to know where how to make a recommendation. I would always back up and say knowledge. You need to have the knowledge to go in so you can understand if what you're being told is in the realm of yes or in the realm of no. And I would say that everything in the book should put you in the position where you can go in and be like, oh, okay, I'm getting good information. That's right. Or wait a minute, I'm bleeding heavily based on these things that Dr. Gunter wrote in her book. Why are you not doing these blood tests that she recommends, right? Take the book in. I'd say every doctor in Canada knows my name. If it's in the book, you'll probably get the test. I mean, you shouldn't have to do that. I mean, you shouldn't have to. But I can't fix the entire system, but what I can do is, give people the tools to go in and get things done. I mean, one of the problems with getting iron infusions is none of the hospitals are staffed to do it.
Yeah.
So, So you might end up blaming your family doctor for not getting it, but if they've been told they can't refer for an iron infusion, what are they supposed to do?
Right. Yeah, absolutely. And so I guess as a follow-up to that, how can good information change the experience of menstruation for women?
Like,
Yeah,
yeah, so it lets you know if you're getting crap advice or if you're getting good advice. It also tells you that, oh my God, that person online, I should block them. Don't let somebody who spreads disinformation into your feed block them. You want to tell the algorithm that you don't want to have access to them. Also, just hearing about the fact that, for example, in lots of places, people can't get IV iron because there aren't enough nurses to do it and because they're all giving chemotherapy. Not that chemotherapy isn't super important. I'm not saying that it isn't,
yeah,
but it shouldn't be an either or. Call your politician. If you can't get access to healthcare, a large part of that is because of the people who are making decisions about allocating money, about allocating what they're going to reimburse. And something that people probably don't know is you get paid shit for doing office gynecology in Canada. So if you want to sit and talk to somebody about their iron deficiency and prescribe their iron and talk to them about nutrition, you're probably going to get $32 Canadian. And you got to pay your office staff with that. You got to pay all these things, right? And so office gynecology, which is a large part of gynecology, is one of the poorest reimbursed aspects of healthcare. So if people are getting paid more for doing other things, what does that say about what we value, right, as a society? Everybody's here because of the menstrual cycle, but the people that sort of poor reimbursement for office visits hurts the most are people with menstrual cycles. Because if you don't have a menstrual cycle, you don't have to go to the doctor when you have heavy bleeding. You don't have to go when you've missed a period. You don't have to go for all of those things associated with it. If you're a 30-year-old guy who's healthy, you don't need to probably go to the doctor at all, right? Maybe you need to get your lipids checked every 5 years. I don't know, or something like that. But if you're somebody with a reproductive tract that, a uterus and ovaries, you need to go in for cervical cancer screening. You need to go in for all other kinds of screening, for sexually transmitted infection screening. And then if you've got bleeding issues, you have to go in for that. So the fact that the healthcare system is weighted towards not giving those people time in the office that uniquely disadvantages women.
yeah, yeah. And as you know, access to primary care in Canada is we're having a real crisis in accessing primary care. And one of the issues, there's no question, is around the funding models for primary care physicians.
Yeah,
Um,
and someone told me there's some, ophthalmologist in Toronto that makes like $8 million or something. And I'm like, I just don't think a healthcare system that allows that discrepancy just seems to, you know, is serving the people, and that's who the healthcare system needs to serve. And I would tell everybody in Ontario that your currently elected government has no interest in fixing the problem. They're happy for you to go to a naturopath where you will get inferior care because they don't have the same training, and then they'll be able, that they'll phase out primary care. So just keep that in mind that there is an active dismantling of the healthcare system directly from the government.
that brings up a really a point that I found really interesting in your book about naturopaths and comparing the training to physicians and sort of other allied healthcare professionals and other people who work in this field. I wonder if you could talk a little bit about the role of naturopaths and how that compares to sort of traditionally trained physicians.
Yeah, I mean, you couldn't pay me enough to go to a naturopath. I'll just say that. I mean, they're taught that homeopathy is real and that's magic. So that's a large part of their training. Would you go to a pilot who thinks that magic carpets are real? You wouldn't probably want to pilot flying your plane who also, if he came on the loudspeaker and said, hey, you know what? I just came from my magic carpet course and I am so thrilled to tell you that I've learned a lot about magic carpets. You probably would not feel very comfortable with that pilot. So, naturopathy is not based in science. It's really not. When medicine diverged from religion, which is what medicine used to be really tied closely to because of germ theory, it went down one pathway. And naturopathy was the other offshoot. The idea that you can heal yourself with nature is simply not borne out. And I can't think of one study done by the field of naturopathy that has changed the way we practice medicine. So I would just caution people that, the training is significantly different. Many of the principles they're taught are not backed by evidence-based medicine. And and they push supplements. And this idea that a supplement is going to fix you, which you should think about a supplement as an unregulated, untested pharmaceutical. And lots of people say, oh, but supplements have Health Canada's approval. Well, let me tell you what that approval is. That approval is a company telling Health Canada what they have in their product, and Health Canada going, okay, that's what it is. There was a study several years ago published, I think it was in 2018 from Edmonton, where they pulled prenatal vitamins off the shelf and tested them. I think it was something like 20% had significant amounts of lead in them. It's prenatal vitamins. So the idea that Canadians have a safer supplement supply is absolutely not borne out by the literature at all, which I find really fascinating, because why doesn't Health Canada say, if you want to introduce your supplement in Canada, it's a $250,000 filing fee. And so we can test your product and see what's in it. And then we can periodically test products that are on the shelf to make sure it's the same. That could easily be done at no cost to the consumer. And, I don't know why. I don't know why they don't want to do it, but be a good thing for somebody who's working on a PhD maybe to think about that kind of model, because, a drug is tested, it has to have what it claims. Drugs are batch tested. You hear about recalls all the time. And because oh my gosh, we tested this, it has this impurity, we got to pull it off the shelf. So you don't get any of that with supplements. So just, it's buyer beware.
Yeah. Okay. Another audience question. Do you see the midwifery scope increasing beyond fetus-centric pregnancy to help support these healthcare gaps for those who have female reproductive organs?
I don't think I can answer that question because I'm not familiar with what midwives are taught about general gynecology. So I don't think I can answer that question. I think if anybody has adequate evidence-based training, there's all kinds of room for them. But so that would really be up to, the College of Midwifery to be, to say, we're going to invest in this kind of evidence-based training, and then go from there.
Super. Another question around sort of treatment. So in your opinion, is PMDD underdiagnosed or undertreated? And how do we normalize discussions around mood and menstruation?
I'm not sure I'm aware of data that it's underdiagnosed. I think that, we have some fairly good studies, I think, on the incidence, probably undertreated, yes. Although I'm not really aware of a study that specifically looked at that. But yeah, I would imagine that it's certainly probably undertreated. That'd be my guess. I think that it's really important to normalize talking about all of the health conditions that are associated with menstruation. And I think it's also really important for us to move away from, talking about like feeling bitchy or angry, or, using sort of these sort of like hormonal slurs, because there actually are people who have real medical problems associated with their menstrual cycle that affect their mood and things like that. And we can kind of water down that experience, and make it seem like it's not like really a thing, but there actually are people with really severe issues related to the effect of their changing hormones. And so, I think that, we just need to start talking about it in a way that's, again, evidence-based and factual. And yeah, definitely there are a small percentage of the population who really does suffer with PMDD, and there are treatments. And there's a whole chapter on it, on PMS and PMDD in the book.
In the book, yeah. Okay, going back to my questions. So you had mentioned at the outset around the myths. And there's lots of really, really interesting myths in the book. I think one of the ones that I found most entertaining was or most interesting was the myth around cycle syncing, that women's cycle. I think back to my first year of university and residence and all of this chatter about cycle syncing. So I'm wondering if you can talk a little bit about that myth, some of your other favorite myths. There's some great ones in the book.
Yeah, so cycle syncing is not a thing. I think the concept comes from a bad study that, was not for the, it's always hard looking back, right? Because what we considered acceptable for a study in like 1981 would, research methods have changed. So I think that that's always important for people to understand, right? So multiple investigators have looked at this concept of cycle syncing and it doesn't happen. It's just math. If you take two randomly occurring events and line them up, they will at some point merge and other times diverge. And in the same way that, you might be behind somebody and your windshield wipers are on and their windshield wipers are on, and there's a period of time where they're totally together and then they're different again, and then they're together again. That's what you're experiencing. So it's not that there aren't times where you're noticing that they're happening. You're just only remembering the times when they happen together. Also, there's no biological platform for that to happen. So humans don't have pheromones. The pheromones have never actually been identified. So that's a really important thing from humans. Animals different. And we also don't have a functioning vomeronasal organ, which is the organ to detect pheromones. So nobody who has advanced the idea of cycle syncing has ever given a biologically plausible explanation. And also, I hate it because it makes women sound like they're seasonal breeders, right? And it's this idea that your own hormones aren't controlling your body. You're such a weak creature that somebody else's hormones can kind of drag you in. Like, and who's the alpha female that does that? To me, this idea of an alpha female is some kind of like male fantasy. So, I don't know. I feel it's very misogynistic at the core. But yeah, it's not supported by science. Another common myth is that the color of your menstrual blood has any meaning. It doesn't. It's just oxidized if it's dark brown or black. If you've ever had a blood stain on something and you go back a week later and you see it's really dark, it's because it's been exposed to oxygen. If your menstrual blood is just very pink tinged, it just means there's a drop or two and it's diluted in cervical mucus. Menstrual blood is blood. It's just blood from you that has come out of the veins and the arteries in your uterus. And nobody wonders when they draw blood from your arm if it's a different color, different times of the month, right? People have even looked, the hormone levels are the same in menstrual blood. It's just blood. So yeah, but there are all kinds of period coaches who would have you believe that the color of your blood means something, and they're going to sell you a diet and a supplement based on that.
Yeah. Yeah. No, as I say, the really found some of those myths very, the
Right.
debunking of the myths was great.
And
Uh,
another one is the idea that the moon has anything to do with your menstrual cycle.
right.
And that's one, like, so if it did, what would happen to people up north? Right? If
Yeah.
you live like somewhere where you have, the long night, right? If you're up in the Arctic Circle, then what happens? You have like one long period? Like how if the moon controlled your cycle, could people be living anywhere except the equator,
Right.
right? So that doesn't make any sense. Also, that would mean then everybody would have a period at the same time because like with the tides, right? Everything happens at the same time. So it doesn't make any sense. And in fact, it comes from a misunderstanding of the origin of the word. So, both, the moon and menses have a common origin, which is sort of like a cyclic occurrence, right? So the ancients called menstruation, they use that term because they noticed it came about once a lunar month. Not that it was the moon bringing it. It was a cyclic occurrence, like the moon had a cyclic occurrence. So it's homage to that, not anything else. It doesn't mean the moon actually has anything to do with it.
One of the important themes again that arise in this book and your other work as well as sort of around the systemic sexism that kind of exists in medical research and education, which you've touched on, and that that makes it hard for patients sometimes to give meaningful, informed consent because the research is just sometimes not there. I'm wondering, where do you think, if you had to sort of prioritize research areas in women's reproductive health, where would you start? I'm sure there's lots of lots to
Yeah,
be
it's,
done. Where would
it's
you
hard to
start?
pick favorites, but I think there's kind of like three big areas that I think um, would unlock a lot of other things too. So one is, why women are more likely to get many autoimmune conditions. And we just don't have, I mean, and with some of them like MS, it's like catastrophic. So I think MS is like 20 to 1. Some of them are more like 4 to 5 to 1. So why is that? We have some general ideas, but we haven't really drilled down enough on that. And I think that if we could understand more at a cellular level why that was happening, we might be able to design more therapies. So I think that that's one area. The other is really endometriosis research. I've been in medicine for over 30 years, and I still think we don't really even understand what causes it. Pain is very complex, first of all. So there's that. But we don't understand, like, why does one person who's full of endometriosis have like no symptoms at all, and another person have very little bit and they have terrible symptoms? And people can have, endometriosis in places where they don't have pain and feel pain in other places, so is endometriosis an inflammatory trigger that gets something else going? Is the endometriosis not even really the cause? Is it something else related to it? Is it a marker for something else that's going on? So we don't really know that. And I think that while it's not really sexy because it doesn't give us drugs immediately, I think we really need to have a better understanding of the basic biology of endometriosis. So there's that. And then I think we also need a lot more research for polycystic ovarian syndrome, which is the most common hormonal condition for women of reproductive age. 10% of people are affected. And it's a very, very complex process. And that doesn't mean that we can't solve the problem. We've solved all kinds of really complex things in medicine. I mean, we can give people bone marrow transplants, for God's sake. So don't tell me that we can't, sort out complex stuff. But it is complex. We don't understand the signaling that happens in the ovaries that ends up resulting in a lot of other aspects of it. And part of that is because most people are aware of the menstrual cycle in the sense that there are groups of follicles, immature eggs, there's signaling from the brain, and those start developing, and then one ovulates. However, that group of eggs that gets stimulated by the brain, they weren't just sitting there. Those eggs had a 300-day journey to get to that development point. So they were all in hibernation 300 days before. And slowly over those 300 days, they gradually got to the point where they can accept the hormonal signaling. We don't know why only some get pulled out each time. We don't understand the timing of that. It seems to be maybe along that pathway where some of the sequence of events that leads to polycystic ovarian syndrome happens, but we just don't know. And I mean, it's very hard to study. You can't go ahead and start taking ovaries out of normal, healthy people, right? Because that wouldn't be ethical. And only studying diseased ovaries, well, those might be abnormal, right? So, and animal models only get you so far because they're a little bit different. So I really think if we could unlock a lot more of that like biological process with regards to PCOS, that might also help us understand more about infertility or help us understand more about other things. So I think those are kind of three of the biggest areas that I would think of, but I'm sure there's many others.
Yeah. Okay. I'm going to do a last call for questions. So if you've got a question, pop it in the Q&A now, but I've got a follow up to that. I'm wondering, I'm going to take you back to the Lancet article. The Lancet's really designated women and health as one of their areas of focus in 2024. Do you think that we're headed in the right direction? Do you think the sort of priority on women's health research is shifting? Is the landscape changing?
I think everybody's talking a good talk, so we'll see. I've
The
been doing,
rubber has to hit the road.
I've been in medicine for over 30 years, and I don't know how much of this is lip service. I don't know how, the one thing that I'm sure everybody who's in academics knows that there's a lot of glass ceilings still. And the people making the big decisions at the top, it doesn't matter how many women there are going into medicine. It doesn't matter how many women there are who are, going into OBGYN. The top positions are still mostly male run, and the people who are designating the research dollars. And I'm not saying necessarily that women are going to do a better job picking things. However, they haven't got a chance yet. And so this is where we are. So, yeah, so, I think that, only time will tell. I mean, obviously more funding is great. It's really fascinating to me how little of this has been, of interest to pharmaceutical companies because there's tons of money to be made. I mean, if you had a drug that could treat PCOS, I mean, the birth control pill is actually very effective. But if you even had a better one, great. If you had a drug that could, stop endometriosis in its tracks in the same way we have drugs now for inflammatory bowel disease, you make a fortune. But what it tells us is most pharmaceutical companies or many drugs come because of basic research that was initially funded by the government. So the government does this, like they fund these labs, there's also sort of these seed ideas, and then those start to percolate, and then away to the races with the pharma. And so if you're not spending the money to do that basic research, you're telling people it's not of value. If you're not seeding the ground, you're not going to get any plants. So but I would also caution people that research takes time. And because we don't understand a lot of the basic biology, like I don't think in my lifetime we'll answer the PCOS question. I mean, maybe we will, but you know, there's still new diagnostics that haven't been invented. And so, when I was a medical student, we just kind of maybe thought HPV was involved with cervical cancer. We didn't really know. But also understanding we didn't have the technology to identify HPV. PCR hadn't been invented. The genome hadn't been sequenced, right? So then we developed all these other cool technology that allowed us to then do all this other research. And now you can prevent cervical cancer with a vaccine, right? So it's not like we're not capable of great
Incredible.
things. It just takes money and time and smart people.
Okay. Last question to close. So from your perspective, what can we do as lawyers and researchers in law and public policy to be better advocates for women's reproductive health?
Well, I hold governments accountable, I think is the message that I would have there. The systematic underfunding of, primary care has a bigger impact on women than it does on men. And that's the reason why it's allowed. Um, you know, I that's why I believe it's allowed. And so I think, holding politicians accountable is a really important thing. But I mean, certainly in Ontario, I mean, you have the situation now where you have to opt in to learn about sex education in schools. I mean, how that's not a human rights issue and how that hasn't been taken to the Supreme Court. I mean, you guys are all the lawyers, but this idea that, and that's a particularly harmful message, the opt-in, because when you read that as a parent, opting in, oh, that must be dangerous. That must be bad. I don't want my kid to be involved with that. But if you teach children less, then they're going to be less likely to demand access to a primary care provider, right? They're less likely to demand access to the medications that they deserve to have. So there's a lot of financial benefit if you're a government who doesn't care about your population in not educating them. So this idea that learning about your body isn't an educational right. I mean, like otherwise, if you don't need to learn about the basics of your body, well, then why should you bother to learn how to read and write? Like, it's as basic as that. So I don't know. I don't know much about the law, and I don't know much about those kinds of things. But I don't know. It seems to be that's kind of like a human rights violation to not be teaching everybody, to not require it in every school. I don't care if you're secular or religious, or secular is religious. I don't know. I don't care. I don't care who you are. Like, if there's reading and writing standards, there should be basic biology standards in schools as well.
Thank you, Dr. Gunter. We appreciate the time you spent with us this evening. It's been a real pleasure, and I wish you all the best on the rest of your book tour.
Thank you. Thank you so much. Thank you for having me. I hope everybody has a good evening, and I hope you all stay warm. I guess I'm in Winnipeg. It's really cold here. I brought the snow apparently. So
Stay warm. Thanks again.
thank you.
Have a
Bye-bye.
great evening. Bye.